morning. We've been chatting a little bit before the camera turned on. I am Jeffrey Cordes. I'm a physician here at the medical school here in San Antonio, and my main job is I'm the director of the Geriatric Psychiatry Residency Program, and also I have a clinical practice at the VA next door at the Audie Murphy VA Hospital. Actually at the Frank Tejeda VA outpatient clinic, where I see entirely elderly folks in my outpatient practice, and it serves as a teaching site for our residents and our geriatric psychiatry fellows. Today I've been asked to speak about psychopharmacology and older patients, and what I'd planned to cover are these topics of discussion. First, I'd like to go over some general pharmacologic principles. And this is a diverse audience that I'm speaking to, and some people might be physicians in the future and others are not. So I've tried to prepare this to talk about the big picture rather than the finer details. We'll go over these broad classes of medications: the antidepressants, the anxiolytics, the anxiety medicines, and the antipsychotics, and the cholinesterase inhibitors, and some people refer to these as the cognitive enhancers. We'll speak about these in general detail and then in more specific detail as we go along. Let me just say a few opening comments, though, that in the approximately 12 years or so that I've been associated with geriatrics and psychiatry, there's been a tremendous increase in the number of medications that are available. And if I were doing this presentation at the start of my career, most of the information would not be available. And the decade of the brain of the 90s really was the decade of the brain. I mean, the amount of knowledge just mushroomed, and most of the things that we use now were not available at that point, except for some exceptions. Also, these classes of medications that I've broken down here really are artificial distinctions as to what their uses are. So some medications, such as antidepressants, are used for other indications, and likewise for almost all the other agents. They have more than one indication, and their general category as listed there really undermines what their actual clinical applications are. All right, since this is a CME talk, let me just disclose who I've had financial relationships with in the past. I've served as a consultant for Janssen Pharmaceutica, Novartis Pharmaceuticals, Eli Lilly and Company. I've also been on the Speakers Bureau for Janssen and Novartis. All right, so the general principles we'd like to cover today are basic pharmacologic principles that are true for all medications, and that includes psychiatric medications. And the two general areas that we'll cover are pharmacokinetics, and this has to do with how the body handles a drug that's administered. And the other issue is pharmacodynamics, and that's basically how the drug handles the body, how the drug actually acts upon the body and causes an effect. Okay. So speaking more specifically about the pharmacokinetic issues, we need to go over the issues of absorption, how the medication, usually an oral medication, gets into the body, how it's distributed throughout the body, how it's broken down by the body, and how it's eventually eliminated. And pharmacokinetics, we know a lot more about them than we know about pharmacodynamics. And for most of the medications, we only have a general notion as to how the medications actually work. But for pharmacokinetics, this is something that's more easily measured and studied, so we know much more about this area than the other. In any event, absorption, in aging, there's changes that occur in the GI tract that might be relevant when we're administering medications. The first thing that you need to know is that, in general, for the elderly, the absorption is not much of an issue. In certain situations, like if someone's had extensive GI surgery and large amounts of bowel have been resected, then that's something that might be more relevant. But for the average patient, the absorption is not a big issue, even though there are certain changes such as GI motility. And any of us who work with the geriatric patients know that many of our patients have constipation because their bowels just don't move stuff along as fast as in younger adults. There's also less blood flow to the GI tract, and that's also relevant because the blood flow goes to the GI tract also takes whatever's taken up as food or medications directly to the liver for processing. That's called first pass metabolism, and that's also decreased. There's also reduced epithelial transport, which means that the drugs that are taken across the surface of the GI tract and into the body is reduced. And also there's a decrease in gastric acidity. It's less acidic, and that's important because some of the medications need to be have to be ionized to a certain degree, and in order for that to happen, the pH has to be right in order for them to be absorbed properly. But in general, this is not a big issue in the elderly. A bigger issue is actually the distribution. This is where the drug actually gets spread out throughout the body. And with aging, there's some important changes that do occur with the body composition. And one of those is that there's an increase in body fat. At the same time, there's a decrease in lean body mass. This is mostly the muscle mass in elderly folks decreases. And also there's a decrease in total body water. And the changes in body fat are on the order of, in young healthy adults, the body fat is approximately 20%. And by the late 60s, this is more around 30% or more. So that is an important distinction. And the reason it is that there's an increased volume of distribution then for most of the medications. Most of the medications, psychiatric and otherwise, are highly lipophilic or lipid soluble. They distribute throughout the fat in the body, and if there's an increase in total body fat, then there's more volume for that drug to get distributed in, and consequently there's also a decrease in relative decrease in water available in the body. So the drugs that are water soluble have a smaller volume of distribution. And the impact of this is that if you have a larger volume of distribution, then the drugs don't reach their peak concentration as quickly. They also distribute to a greater area, and they accumulate more, and the body it takes longer to get rid of them. Okay, so they can actually accumulate over a longer period of time. And the other side of the coin is for the water-soluble drugs, they reach peak concentration quicker and have a smaller volume to distribute in. Examples of water-soluble drugs are more of an exception, and these are like digoxin or lithium in the psychiatric medications. So except for lithium in the psychiatric medications, all the rest are lipid-soluble. All right. Other issues affecting the distribution of drugs in the elderly is that there's a decrease in serum albumin as people age. And because this is the major plasma protein, it causes a decrease in plasma protein binding of the medications that patients take. And this is important because most drugs that are given have a certain degree of protein binding. Some of them are on the order of 90% or more, and others are much less. But it's the free fraction, the fraction that's not bound to the plasma protein, that's actually active in the body. So if you have a decrease in the plasma proteins, then the amount of free drug that's active is also increased. So that's very important to keep in mind. All right. So we've talked about the absorption of medications and the distribution of medications, and then how the body breaks them down has to do with the liver metabolism or hepatic metabolism. And like I said before, there's a decreased blood flow to the liver, and also as we age, our livers decrease in size. So that right there tells us that the metabolism is affected. The way the liver actually processes drugs is something that's undergoing active research. But there's basically two phases of metabolism. The first one is called phase 1, and it has to do with oxidation and reduction primarily. And this has to do with the cytochrome P450 system. And you might have heard of this because it's getting a lot of attention in the last few years. Excuse me. Cytochrome P450 system, there's a lot of subtypes of enzymes. There's 3A4, 2D6, and so on and so forth. There's lots of subtypes. And the reason that this is important is because certain drugs only use certain enzymes in the liver to be broken down. And if another drug comes along and inhibits or blocks that pathway, then the drug that usually gets broken down by that system can build up or increase in the system. And likewise, some drugs cause those enzymes to work faster and thereby cause other drug levels to decrease over time. The second phase of liver metabolism is called conjugation, and this is primarily how the body puts these lipid-soluble drugs into a more water-soluble form so they can be excreted by the kidney. And certain drugs really have a limited phase 1 metabolism and are primarily dealt with by the body with conjugation, and that's an important issue that we'll talk about when we talk about medications like benzodiazepines later. All right, and then we get to elimination. How does the body actually get rid of the drugs? It's usually through the kidney, but sometimes also through the GI tract. Primarily, we'll talk about the kidney. As patients age, there's a decrease in what's called the glomerular filtration rate, how efficiently the kidney can filter the blood of compounds that need to be excreted. There's also a decreased plasma flow through the kidney, and this causes a buildup of medications. Serum creatinine is something that we get commonly as a blood test for our patients, and it's a general index of how well the kidneys are functioning. Okay? But in the elderly, this value can be misleading, and creatinine actually is a breakdown product of the muscles and is fairly constant over time. So if this sort of creeps up, we know in our younger patients that their kidneys aren't working as well, and it's a general indicator. However, in the elderly, we talked about already that their lean body mass, their muscle mass is decreased. So even a normal value of creatinine in the elderly might be misleading and suggest that the kidneys are working okay when in fact they're not. Okay? So we need to keep that in mind too. So even a creatinine level that's at the upper limit of normal might actually suggest that the kidneys aren't functioning as efficiently as in younger adults. Also, certain medications like non-steroidal anti-inflammatory drugs, this is like ibuprofen and others, and also other health conditions like congestive heart failure compromise the kidney further, and these are both common situations in the elderly that can affect other drug levels. Okay, I'll talk just briefly about the pharmacodynamic aspect of the drugs. This is how the drugs actually work, and we don't really know that well how most of the drugs work, but it has to do with the receptors that the medications work at, and how many of the receptors there are, and how well the receptors bind to the drugs, and then how that signal at the receptor at the surface of the cell is translated to the interior of the cell, and how the cell responds to the medication, and then how the cell responds to the changes that the medication is inducing. And this is something that we don't know enough about, and in the future we likely will know a lot more about. Some drugs show a smaller effect than in younger adults, but most drugs show a greater effect. We don't know if it's because there's a higher affinity or a lower number of active cells, and this is an area of ongoing research. In general, when we're talking about medications and psychiatric medications, we need to keep in mind that most drugs are not very well studied in the elderly. Most of the trials that lead to their approval for marketing under the auspices of the FDA are generally in younger populations that don't have a lot of other medical problems. So they're not studied in people with diabetes and CHF and COPD, the sorts of problems that we see in the elderly. So a lot of times we don't really know how well they'll work or how well they'll be tolerated until we try them. And within an aging population, there's a tremendous variability between people of the same age. You know, a group of 70-year-olds has a wider variance than a group of 35-year-olds. A group of 70-year-olds, some of them will behave exactly as if they were young adults, and others will be very frail and sensitive to medications. And likewise, if they have any pathological conditions or diseases, then they're likely to respond to medications differently as well. Okay, so basically the usual caveat that you hear is start low and go slow, and that's because of this general concern we have about medications and tolerability. So usually we'll be starting medications at half the starting dose of young adults or less, sometimes a lot less. Okay. Incidentally, some of the things that we'll be talking today go beyond the FDA-approved indications and are more off-label uses. And what I've tried to do today is talk about the practical aspects of using these medications, what I actually do in my clinical practice, and to pass that on to you. So some of this will be off-label and not exactly what you'll read about in the PDR, for example. Okay, as a general class, we have a group of medications called antidepressants. And any of you who've been in the field for any amount of time are familiar with many of these compounds. The older ones were called tricyclic antidepressants, and these came out in the 1950s initially. And quite by chance, they were thought to, they were initially developed as antipsychotic medications in the 1950s after medicines like Thorazine were developed, and that came about by chance because they were trying to get medications to help with tuberculosis, and they found that these medications actually help with psychosis, and then they were trying to develop other medications to help with psychosis, and they stumbled on these that actually help depression. So that's the way medicine has always been and probably always will be, that much of our advances are due to serendipity. Anyhow, we have a whole class of medications called tricyclic antidepressants, and they are similar chemically, and these are amitriptyline or Elavil, nortriptyline, imipramine, diazepamine, doxepin, clomipramine. All of these were the mainstay of treating depression through the 50s, 60s, 70s, and even through most of the 80s. And now they're used less because we have other agents that have fewer side effects. The other major class that's been the mainstay is called monoamine oxidase inhibitors. These are the MAOIs. These are phenelzine, isocarboxazid, and trancypramine, which are very rarely used today, even though they're still very effective and probably are underutilized. And the reason that they're not used very much is they have a well-known association with problems with hypertension when a person eats foods that contain tyramine, and these are the ones when you look at your over-the-counter cold medicines that say, be careful, don't use this with antidepressants, these are the ones that they're talking about. Okay, so for those reasons, they've fallen out of favor, and they do actually also have a lot of side effects. So, in the last 10 or 12 years, like I was saying, the medications have really advanced. The biggest class that we use now are called serotonin-specific reuptake inhibitors, and almost everybody's heard of these, even lay people, because they're advertised. These are fluoxetine or Prozac, sertraline or Zoloft, paroxetine or Paxil, fluvoxamine or Luvox, and citalopram or Celexa. Probably all of you have heard of some or all of these. And the other class is sort of a mixed bag. There's medicines like, these are all in order of appearance. Trazodone, which came out in the mid-1980s, bupropion that came out in about 1990, venlafaxine that came out around 93 or 94, nifazodone around 95 or 96, and mirtazapine just a couple of years ago. So we really have, as you can see, the bottom half of the slide is all the medications that have come out just in the last 10 or 12 years and are really the mainstay of treatment these days. All right, in general, with antidepressants, they all take about 4 to 6 weeks in order to reach their full effect. And even the newer medications that are primarily prescribed have not been shown to be more effective than the older medications that we've had for 40 years. And that's important to keep in mind. And they're all approximately equally effective, like I said. So what determines which ones we select has to do with the dosing schedule, how easy they are to administer. Some are once a day, some are twice a day, and what their side effect profiles are, because certain patients it would make more sense to use one medication over another. For example, some medications are sedating. In a person who's having trouble with insomnia, it makes sense to use a medication that's more sedating. And other people complain of fatigue and excessive energy or poor energy during the day, then maybe a medication that gives people a little bit of a lift or a boost would make more sense to use. All right, specific issues regarding antidepressants is that the tricyclics and the MAOIs in the elderly are generally avoided. I think probably the primary prescribers of tricyclics, that's the imipramine and imipramine and those that we talked about already, are probably primary care doctors and pain specialists. We're using this primarily for insomnia and also for peripheral neuropathic pain, things, chronic back pain, things of that nature. And they're actually quite effective for that, but they're used in very low doses, like 25 or 50 milligrams, whereas the antidepressant dose is more around 150 or 200 milligrams, so in lower doses. But even so, in the elderly, we ought to avoid them. I have patients, 85-year-olds that are sometimes given 50 milligrams of amitriptyline, and they get extremely sedated and orthostatic, and this puts them at risk for falls. So we really try to avoid these. And if you really need to use a tricyclic, you ought to use nortriptyline, which has the fewest side effects of them all. All right, so SSRIs, bupropion or Wellbutrin, venlafaxine or Effexor, Surazone or Nifazodone, and mirtazapine or Remeron are pretty well tolerated generally in the elderly. We start off at a lower dose and titrate it upwards, but they're usually well tolerated, and if one of them doesn't work or is not well tolerated, then oftentimes another one is. And lastly, trazodone is a commonly prescribed medication for insomnia, and it's uncommonly used for depression these days because it's excessively sedating, but that's an advantage if you use it for insomnia. But it is associated with some orthostatic hypotension, so this one should be started at a low dose. People should be cautioned, and you should gradually increase it, although I have some patients that tolerate it very well even at fairly high doses. All right, the anxiolytics, the anxiety medications, are another group that's commonly prescribed. And among them, there's a medication called Buspar or Buspirone, which came out in the late 1980s. And it's a novel agent that's unlike any others that we have. And for certain indications, it's extremely effective and has a lot of favorable attributes that we'll talk about in a little bit. But it's not good for everything. Benzodiazepines, these are what you most commonly think of when you think of anti-anxiety medicines. And I know Dr. Ingmanson in the previous lecture discussed some of these in brief detail. And lastly, the group that I'll put in quotation marks as antidepressants, because they actually have anti-anxiety properties, and these are the SSRIs and the tricyclics and some of the other medications that we usually think of as antidepressants, which are actually anti-anxiety medications as well. So we commonly use those as well, and I'll talk to you a little bit about these in more detail. All right, for generalized anxiety disorder, now when we talk about anxiety, this is kind of a mixed bag itself. Some people are anxious because they almost got hit by a car, and that's a normal anxiety. Then there's also generalized anxiety, where a person is sort of all the time kind of keyed up and tense and preoccupied and worried about things that are just ordinary life issues. And for that kind of a generalized anxiety problem, Buspirone is very effective, and so are the antidepressants I was telling you about. And those are the first line agents for this disorder, and if possible you try to use those. If that's not helpful or effective, then we try benzodiazepines, but they have a less favorable side effect profile that we'll talk about later. Panic disorder, this is a person who has episodes of sudden onset chest pain, sense of impending doom, shortness of breath, tingling, numbness around the lips that comes on out of the blue usually and lasts a relatively short amount of time, on the order of maybe 15 minutes or less, and comes on real acutely and leaves generally quickly as well. And these patients often go to the emergency room because they think they're having a heart attack. And this is a very common problem that actually doesn't come to the attention of psychiatrists all that often, but primary care doctors see this quite a lot. And antidepressant medications are quite effective for panic disorder and ought to be the first line agent, even though benzodiazepines are also effective. Post-traumatic stress disorder is another common anxiety disorder, if you will, and SSRIs have been shown to be effective for that condition. Okay, some other general principles is that Buspirone and the antidepressants are first line for certain conditions because they have a more favorable side effect profile. However, their full effect usually takes on the order of weeks. So this is not something that's going to help the person the same day or within a couple of days, but it takes on the order of weeks. So patients have to be patient and need to take the medication every day and not expect a dramatic change right away. However, in the long run, they're probably better off on these medications because they have a lower risk of dependence and generally have few side effects. So if possible, we start off with those medications. And benzodiazepines have advantages, and one of those is that they work quickly. I mean, some of them work on the order of minutes, and if not minutes, within days, you notice an improvement. However, this comes at some cost, and that's that they generally cause a physical dependence on them if they're taken for months at a time, and then a person needs to be tapered off of them to avoid having a withdrawal reaction. And these are also medications that some patients end up abusing because at higher doses they they give a sense of euphoria. However, most patients don't abuse the benzodiazepines, and they're fairly safely used if they're monitored carefully. All right, other specific issues about the anxiety medications are that with benzodiazepines, we need to keep in mind that there's a number of properties that distinguish them. It's a pretty large group of medications, but they have different speeds of onset, duration of action, route of metabolism, and potency, which clinicians need to keep in mind. And I'll just briefly go over this. Some medications have a very quick speed of action, like alprazolam. This is Xanax. So it works really quickly. Also Librium or chlordiazepoxide, and also diazepam or Valium. These are medications that maybe all of you have heard of, and these all have a quick onset of action, which can be an advantage and a disadvantage. Alprazolam or Xanax is also the one that you hear about being abused the most, and Valium not far behind. Because of that, because it has a quick onset, it's associated with more euphoric kinds of symptoms, and people tend to abuse these the most. Other medications like lorazepam or Ativan have a more intermediate onset of action, and clonazepam as well. And some of them have a slow onset of action, like oxazepam or Sirax. So those are important issues to keep in mind. And also the duration of action. Some of them have a very short action, like alprazolam or Xanax. So this one has an onset that's quick, and also has a duration that's very brief. So these have to be dosed frequently throughout the day, sometimes 4 times a day. And these, likewise, medications and drugs of abuse that people abuse are most likely to use these kinds of medications. For example, cocaine is a drug of abuse that has a quick onset of action and a very brief duration of action. So people tend to use that repeatedly throughout the day, and we all know that from the news reports and our own clinical experience. So alprazolam also has a similar kind of quick onset and brief duration that probably is the reason that it gets so much press about it being misused. Oxazepam has a relatively short duration of action, and others that have intermediate duration of action are like lorazepam, and long duration of action are like Librium, chlordiazepoxide, diazepam or Valium, and clonazepam or Klonopin. And that's a real advantage in many ways, because these longer acting medications are useful for patients who are going through alcohol withdrawal, because we don't want them to have a lot of peaks and valleys between medication dosages. It's better to have them on a dosage that sort of gradually decreases over time. So Librium and Valium are typically used for alcohol withdrawal. Okay, the metabolism of benzodiazepines is important as well. The great majority of them need to go through that phase 1 metabolism that I was talking about earlier. And that's important because the phase 1 oxidation is what is most impaired as people get older. It's the ability to use the microsomal enzyme system, that cytochrome P450 system, to break down these compounds that slows down the most with aging. And the phase 2 or conjugation system is relatively intact even in elderly folks. So medications that primarily go through the conjugation step are preferable in certain situations. And this is lorazepam or Ativan, and oxazepam and temazepam. Okay. Let's see. So in people with liver disease, for example, we would want to avoid most benzodiazepines and use primarily Ativan, Sirax, or Restoril if we need to use a benzodiazepine. Okay, and lastly, potency of these medications. Clinicians who prescribe these medications need to keep in mind that the milligram strength, the potency of these varies a lot, and you need to have some way of equilibrating these medications if you're going to prescribe or change a person from one to another. You need to know about what the strength of the medications is. If you look at lorazepam or Ativan being 1 milligram, you can see that alprazolam or Xanax and clonazepam or Klonopin are more potent than lorazepam, and others are less potent. And keeping these dosage equivalents in mind is important. Okay, also other things about these medications is that some of them are only oral medications, others can be administered IM, and some can even be administered IV. So if you're in a certain setting where you have IV or IM capabilities, that would be useful to know. Probably the most commonly used benzodiazepine of them all these days is lorazepam or Ativan. Probably most of you have heard of that if you deal with patients. And the reason is that it's got that nice conjugation-only pathway, so even if they have liver disease, it's usually safe to give. It can also be given IM or IV, so people in an ICU who maybe can't even swallow medications can receive lorazepam if they're agitated, for example, through the IV line or through an intramuscular injection. So that's why it's such a popular medication, because of those qualities. All right, the antipsychotic medications is another group of mixed agents. They're the older typical agents that probably everybody's heard of, like thorazine or chlorpromazine and thioridazine or Mellaril, and Baradol or Haldol, and flufenazine or Prolixin. And then there's also newer, or what they call atypical agents, which started with Clozaril or clozapine in about 1990 or 91. And through the decade of the 90s, we've had 4 or 5 other medications come along down the pike, and these have, over time, become the first-line agents for people with psychotic problems. And again, these have only been studied really well in younger schizophrenic populations who have psychosis. So in the elderly, that group of patients, the older schizophrenic, is a minority of the patients who actually have psychotic problems. So oftentimes patients with dementia will have psychotic symptoms and need to be treated, and frequently we will use these atypical agents even though they haven't been studied all that well in the elderly. They are fairly well tolerated, however. Okay, so the general principles are that except for clozapine, they're all approximately equally effective. You've heard that before from the other things I've said today. And that's really true. Clozapine is the gold standard for taking care of patients with schizophrenia. It's substantially more effective than any of the other agents, and on the order of 30% of patients who fail other medications respond well to this medication. However, it's very tedious to give because they need a blood draw every week to monitor for neutropenia, and for that reason it's only uncommonly given when other medications fail. So what helps us decide which medications to give is, again, it's the side effect and the route of administration and the dosing schedule that helps guide which medications we select. So in general, the typical agents have more side effects. However, they can be given not only orally, but IM and IV, certain agents, like Haldol, for example. They also have a long-acting form, an intramuscular decanoate form, so for people who can come to the clinic and get a shot every 2 or 3 weeks and not have to take pills at all between visits, that's a real advantage that the newer agents don't have. All right, they also have side effects, though, and one of those is Parkinsonism. They can look exactly like they have Parkinson's disease because of the dopamine blocking aspect of these medications. They can also have dystonias. This is like muscle cramps. This can affect the neck or the tongue and can be very painful. They can also develop a very worrisome problem called tardive dyskinesia. Tardive means late onset, and dyskinesia means abnormal movements, and this is the sort of grimacing, lip-smacking, writhing kind of movements that you'll see in patients, and it's very common in the elderly in nursing homes when they receive these medications, and it can also happen after strokes in certain areas of the brain. These older medications are also frequently associated with weight gain and sedation, although not all of them. All right, the atypical agents, these newer agents, have fewer side effects. For now, they're only available in oral forms, and that's going to change probably within the next year. And they're far more expensive than the typical agents. And it's also important to know that if you increase their dosages, they become more typical in nature. So all those side effects we talked about on the previous slide can be seen in the newer agents if you push the dose high enough. And an exception to that is quetiapine or Seroquel, which can be used even at fairly high doses without causing that Parkinsonism. So in certain conditions like patients with Parkinson's disease and dementia and visual hallucinations, or patients with a condition called Lewy body dementia where they're really sensitive agents, they can be given Seroquel or quetiapine without significant problem. And the last group that I'd like to cover today are called cholinesterase inhibitors. Some people call them cognitive enhancers. And these are the medications that have been studied in the last decade and have been approved for the treatment of Alzheimer's disease. And you may have heard of some of these already. The first one that came out was called Tacrin or Cognex, and this came out in around 1993. It was really a landmark medication because it was really the first medication that was able to show in well-designed studies a difference between itself and placebo in patients with Alzheimer's disease. And previously there was nothing available at all that had been shown to be effective. So that was a real big deal. The next one that came out was donepezil or Aricept. That came out in around 96. Rivastigmine or Exelon came out about, is it 2 years now? And also galantamine or Remenil, which is, will almost be out a year in May. And these are all medications that we have in our armamentarium for Alzheimer's disease. Okay. In general, they're, again, all approximately equally effective. And when I say this about each of these classes of medications, that they're all approximately equally effective, some of that is because they haven't really been studied head-to-head very well. I think there's a disincentive for the pharmaceutical industry to actually study their compounds against another compound unless they know for sure they're going to win. So these studies really haven't been done enough. But as far as we can tell from the data that is available, they're all approximately equally effective, these cholinesterase inhibitors as well. Okay, and they're fairly well tolerated as a class if you titrate them slowly. And this is like changing the dose on a monthly basis, not daily or weekly, but on a monthly basis. And the only one that's not very well tolerated is that first one that came out, Tacrin or Cognex. And it was associated with liver problems and severe GI upset. And so only about a third of the patients could actually tolerate a therapeutic dose. But the ones that have come out since then are much better tolerated and don't have that problem with the liver toxicity. All right, it's worth saying, however, that the benefits of these medications, although they're statistically significant and definitely, it's definitely true, their benefits are actually relatively modest. We're not talking about a cure for Alzheimer's disease. We're not talking about, in most cases, a reversal of any of the loss of functioning or any long-term, clearly established delay in the illness. And they all are very expensive medications. Okay, and to sort of summarize on this slide, I have some of the similarities and differences between the three medications we use now. We hardly use Tacrin now because of the problems I described already. And they all block an enzyme called acetylcholinesterase. The one, rivastigmine or Exelon, also blocks another enzyme called butyrylcholinesterase. Galantamine or Remenil also works on the nicotinic receptors within the brain, and there's a theory that that might help with the cholinergic transmission within the brain and add an additional benefit that perhaps the others don't offer. And their half-lives are different. Donepezil has a long half-life, which is an advantage generally because it can be given one time a day. And the other two medications have a shorter half-life and have to be given twice a day. So for some families, that's a big deal because if you have a person with dementia who's not wanting to take medications, if you can reduce the amount of times you have to try to get the person to swallow a pill, that's you know, an important consideration. Also, we talked about the cytochrome P450 enzyme system. Rivastigmine or Exelon doesn't use that system at all. It's conjugated. So if a person has liver disease, that might be the best choice to use in the elderly. And regarding the plasma protein binding, galantamine or Remenil has the lowest amount of plasma protein binding, so it's less likely to displace or dislodge other medications from those plasma proteins like albumin and cause toxicity of other drugs. All right, well, let's see. In summary, then, we've talked about the pharmacokinetics that we know about medications in general, and how we know a lot more about the absorption, the distribution, the metabolism, and the elimination of drugs. And we know far less about how actually the medications work. And what we don't know is why elderly are more sensitive to medications in general, and why lower doses are required in the elderly. Even, for example, there's some data that shows that it's not that the concentration in the bloodstream is any different, they just have a bigger bang for the buck in the elderly, and we need to keep that in mind when we're prescribing our medications. We talked about antidepressants and how most of these medications are used not only for depression, but also for anxiety. We talked about anxiolytics and the relative advantages and disadvantages of the compounds that are available. And we talked about some of the finer points about the benzodiazepines and how those need to be considered in selecting the best agent for a given patient. We talked about the antipsychotic medications in general and some specific terms as well. And we've talked about the cholinesterase inhibitors. I think we have a little bit of time left, about 5 minutes perhaps, to talk about other things. I don't know if there's questions, or if I can talk about some other things off the top of my head quite easily as well. No questions? What about at the remote site? Does somebody have a question there?
She can't transmit.
Oh, you can't transmit, yeah. Okay.
The only thing I noticed is that our doctors with Alzheimer's, they start with Aricept, if it doesn't work, they just switch over, they go down the line to Exelon, and now they're with Reminol.
Why don't you use the mic?
I just noticed that most of our doctors start with Aricept for Alzheimer's, and then if the patient doesn't say any improvement, then they start with Exelon, they move down to Reminol. Basically,
Yeah.
What do you think?
I wonder, it's probably not based on any known differences in their efficacy. It's probably mostly that Aricept has been out longer, they're most comfortable prescribing that. It has a one-time-a-day dosing schedule, and then if that doesn't work, then they try the others. It probably has less to do with science than just clinical experience, and that's probably true in most places, I would imagine. Yeah, that's a good point. There's other areas that I didn't really talk about today. In the elderly, we're frequently using medications of really all of these classes for what we think of as problem behaviors, like in a nursing home or in persons who live in the community. They have problem behaviors. Sometimes that's agitation, irritability, aggressiveness, and things like that. And doctors are frequently having to prescribe medications for that. And most of these medications haven't been very well studied for that, but we're having to prescribe them anyway, and we know that some of them work pretty well. Let me just talk about my general approach when I'm having a person with problems with irritability and grumpiness and oppositional behavior that's difficult to manipulate. Say this is a person with dementia. Usually my first line medication is not an antipsychotic, and it's not a benzodiazepine for anxiety or sedation, even though lots of doctors do prescribe those first. My first line medication is an SSRI, a medication like Prozac or Zoloft or Paxil. These medications are extremely effective in my clinical experience for that irritability, that grumpiness. And when you think of the word grumpy, that goes with what word? Old man, right? I mean, we don't think of grumpy 30-year-olds that much. Yeah, they made 2 movies about it. Yeah, and grumpy goes with old man. And I think grumpiness is a part of old age. It's not a normal part of old age, but we see it a lot. And SSRIs work terrific for this. And I told you that these medications take 4 to 6 weeks to work for depression, right? For irritability and grumpiness, they work within just a day or two. I mean, they're really quite effective. I have probably 2 or 3 dozen patients on this medication, on these medications for this indication, and their families are very impressed with how much benefit they get and how few side effects they have, and pretty much any of them work. In my experience, Prozac or Zoloft or Paxil or Celexa, they all work pretty well for this indication. And when their prescription, there's a gap between when the medication gets refilled or they get it in the mail or whatever, and the patient is off the medication for 2 or 3 days, they notice it right away also, that they get irritable again, and they're on the phone calling me, doctor, I need to get my Prozac, my wife can't live with me, or something like that.
Is that good in combination, like with Exelon for people with Alzheimer's?
Well, it hasn't really been studied very much,
but
but I use it all the time, and I haven't had any problems, yeah.
They complain that they're irritable,
Yeah.
grumpy, aggressive.
Right, so what I try to do is break it down. If they're telling me that the person is irritable and grumpy, short-tempered, complaining about little things, all these kinds of things, then that's what I look for. If there's a way I can work an SSRI, and that is very effective and very helpful and very easy to do. And they notice the result quickly, and they're very happy. Because if a person isn't grumpy, then they're much easier to live with. In fact, you can most of the families I deal with have a loved one who might have dementia, and they can accept that the person doesn't have a good memory. But what's hard to live with is the irritability and the grumpiness and the oppositional behavior. So if that can be reduced, then that makes a world of difference for the caregivers as well. How am I doing on time? Good. Okay. I don't know if there's any other questions or other things that we should discuss. You want me to give you a break and let you go to lunch early? Let me say a few other things. I didn't talk about mood stabilizers. People with bipolar disorder or sometimes with impulsivity and aggressiveness do well with mood stabilizers like lithium, Depakote or valproic acid, Tegretol or carbamazepine. There's even a whole host of newer generation anticonvulsants that are used. Those haven't been very well studied in the elderly, but sometimes we use those. And sometimes patients have problems with apathy, anergia. They just kind of sit around like a bump on a log and don't do enough behavior. Sometimes we need to use stimulants for those patients. So I didn't really talk about those because those are sort of lower frequency medications, but nevertheless we use those in our armamentarium as well. So I'll use the medications that most people think of as attention deficit disorder medications that we primarily use in young children. I use them in my elderly patients, and they work fairly well. All right, well, I appreciate all of your attention.
What about an old person that's a little prone to alcohol, for instance? Do you have any medications that you say after that
Okay, the question is in an older person that's maybe prone to drinking alcohol, yeah, there's certain medications I'll avoid. I'll avoid the benzodiazepines for sure. And it turns out that the patients that are most likely to misuse medications like benzodiazepines are those who have a history of misusing other things like alcohol or opioids or drugs of abuse. So in patients who misuse alcohol, they might benefit from benzodiazepines if they're going through withdrawal or detox. That's a useful indication. But otherwise, they ought to be avoided because they have a tendency to misuse them. I have a patient that has had a long history of this problem. It comes to mind. All right. Well, again, thank you for your attention, and I appreciate the opportunity to talk with you today.